First of all, I just want to acknowledge that we are meeting on the traditional territory of the Coast Salish people, particularly the Musqueam people who their community is still in this area right here around UBC. For those of you who are visiting, this is a fairly traditional thing we do in meetings. And I'll be talking about Aboriginal health a little bit because part of that is in my portfolio. So I did want to do that traditional recognition of the traditional territory here. I want to extend a little bit the concept of context that Rima was talking about. And do I have a zipper? Just this here?
Yeah, just press
So I want to extend that concept of context a little bit further, because I think we still, in the healthcare system, are very myopic, to use her word. So this is a fairly standard definition of health literacy. People in this room don't need to see that, but it really is this notion that there's a complex interaction of the system, the provider, and the consumer. And that's how we generate health literacy, is through that interaction. On the bottom there, I've identified three real key requirements, and I think that Rima was talking quite a bit about the first one and a little bit about the other too there. So we know that health literacy requires some skills on the part of the provider and the consumer, obviously, but also skills to navigate the system, and there needs to be, for the individual, a feeling of empowerment to seek out information and to take action to improve health. Those are requirements for us if we're truly going to create health literacy. So, as I said, I think we're still stuck quite a bit in the healthcare system around a fairly traditional view of what health literacy means. And this is kind of, your traditional, we got to explain people about their drugs, their medication regime, if we translate it, we educate them about it, we'll explain it to them. But I think we need to focus more on a different way of thinking about the interaction. So this is a drum. It's a symbol for this discussion today of an Aboriginal path to wellness. So many Aboriginal people use drumming as part of their wellness journey. So we need to understand, when we're communicating to Aboriginal people, for example, what is their wellness journey and what does that entail? So we need to empower the relationship. In other words, to create the conditions for the knowledge exchange that Rima was talking about. One of the things that I said in the first slide there was there are a couple of things that we need to think about beyond just the knowledge exchange. It is that context, and that's part of people's context. This is another kind of example where we have a health promotion program where we teach people about healthy eating, and this is the healthy plate, of course, where there's certain quantities of food you should have on your plate and what the categories of food should be, and we try to get people to understand that. But of course, there is other knowledge that the patient, the consumer, has when they come to the table with us. And in terms of empowering them, we have to build on the knowledge that they already have. Giving them just our knowledge doesn't recognize that they already have knowledge about their health and how to improve their health and how to manage their wellness journey. So we need to build on what they already know. So as I said, I'm going to focus a little bit more on the two other aspects or requirements I mentioned at the beginning there. The whole notion of navigation and the notion of empowering people, particularly from the cultural side of things. So my main message, or my central message today, is that cultural competency has to be a foundational element of any organization's attempt to create health literacy. And I'll also mention a little bit about the health equity question, which was raised in the previous presentation, but is very significant for Aboriginal people in this province. So what is cultural competence again? I don't think that needs to be discussed too much with this group. Most of you are familiar with it. But I want to highlight a couple of things in this particular definition. So it's a set of behaviors, attitudes, and policies that come together in a system. And the critical piece here is that it's policies and a system. We do need to support the practitioner and the consumer in the interchange that goes on. Great example is where we will, in our hospitals, have an Aboriginal patient who wants to do smudging, which is the burning of some materials as part of their wellness journey. Well, of course, in most cases, we ain't going to do that because the fire alarms are going to go off, so the system doesn't support that. So we need to have policies that allow for that change to occur. within our hospitals, and we do that now in many situations. Another part of this is that we have to build strengths, and that comes back to this notion that people have already a huge amount of knowledge. We assume that we have the knowledge and we're going to give it to them, and if they could just take it, everything would be well. We forget they have knowledge about their health and how to manage and improve their health that's different than ours, and we need to empower and build on that strength. And then the third part that I want to stress about this is this notion of dynamics of power and privilege. We often forget that there is this dynamic of power and privilege. Many of us will talk about cultural safety as opposed to cultural competency. And if you think about people coming into our large institutions to get health care, many of them come in and don't trust the situation they're in. We tend to be, as we look at our demographic, fairly trusting when we go into a large healthcare institution. But for many people, they don't. For First Nations people or Aboriginal people in this province, they are very untrusting when they walk into a mainstream institution, because mainstream institutions in this country over centuries have decimated their culture and decimated many of the people that they know. So they're very anxious and trustworthy when they go into one of our facilities. And as we know, if you're anxious, and we all know when we work with somebody who's anxious, anxiety goes up, performance goes up for a while. You hit a level of anxiety and performance drops off. And so for many people, when they're in that institution and they're highly anxious, they're not going to hear what you're saying. The communication, the work we're doing to build their literacy around their health and their journey through our system will not even be heard. No matter how smart they are, no matter what skills they have, they will be too anxious to even hear what we have to say. So we need to deal with that dynamic of power and privilege and understand the context that that patient or client is coming from. So just to reiterate a little bit about why this is important, from a healthcare side of things, we're, as big institutions, we concern ourselves a lot with risk. So we analyze risk and try to avoid risk. So we've done some work in Vancouver Coastal Health, looking at risks that face us. And we've looked at the risk associated with the notion of cultural competency. And so we know when we do a kind of a mapping of it, we have identified the very things that I've talked about that constitute risk if our providers are not culturally competent, if our system is not culturally competent. So there's three big ones that we identify. One of them is that individuals may delay, defer, or avoid seeking treatment. So we don't even get them in the door to work with them around health literacy. A second big one is around individuals may not follow through with care. So even though we have given them instructions, they may have gotten the instructions, they may understand it, but when they leave, they may not follow through. So those things actually manifest themselves in real-time problems for a health authority like ours. So for example, it may mean that our emergency departments are busier because patients who've been discharged don't follow through, they don't go to primary care to get help, and they end up in our emergency departments. So it's a huge, significant issue if we think about the very concrete things that can happen when we don't attend to cultural competency in the system. I want to just make a mention of health equity. It was mentioned in regard to the situation in the United States. Clearly, when we look at health inequities in our system, and those are the unequal situation we see in terms of people's health and things that are avoidable in terms of that inequality. When we think about that, we know healthcare only plays a very small role in that. I mean, it's the bigger social determinants of poverty and low income and education, et cetera, that really affect a lot of those inequities in our society. But there is a role for healthcare to play in reducing those inequities. And clearly, if we don't attend to health inequities, we have the potential to actually exacerbate them. So if we don't help people seek care when they need it, when we don't get people to follow through on their care, we have the potential for exacerbating those inequities which exist within our system. So I'd like to talk a little bit very quickly about the Aboriginal work that we are doing, Aboriginal health work we're doing in Vancouver Coastal Health, and kind of wrap up with the Navigator program that we operate, which is, I think, a very important part of our cultural competency and health literacy activities. So for those of you who don't know, our First Nations people and Aboriginal people in Canada have much lower life expectancy than other Canadians. I won't go into the numbers. You can get those afterwards. We have a fairly robust program in the province of British Columbia to try to close that gap, that inequity gap. We actually have a Aboriginal First Nations Health Authority that's been created to lead that work. And these are some of the targets that have been set to try to bring close that gap. And chronic disease is a huge inequity gap that we have in that population. Diabetes rates are much higher. Other chronic disease rates are much higher in the Aboriginal population. So from a cultural competency point of view, the first thing that we have done is try to better understand the way of knowing of the First Nations population and what they perceive and understand to be the factors that contribute to health in themselves and in their community. And this is a wellness model that they've developed, the First Nations Health Authority here has developed. And it's interesting because, again, if you're thinking about context and trying to build the relationship between the system, the individual consumer, and the provider, you need to think about things like land. A great example is in terms of obesity and obesity reduction and all the chronic diseases associated with that. Trying simply to teach people about eating well is not the solution for, I don't think for anybody, but for Aboriginal people in particular, because of the way they think about land. So where we're most successful in having First Nations Aboriginal people work on reducing obesity is when we take them to a community garden out here at UBC, for example, where they're actually back on the land, where they're looking for their traditional foods and their traditional medicines. And then they become engaged and they begin to change their wellness journey. So it is understanding their way of thinking about health and wellness that will make a difference. Some of the work, just concrete things we're doing in Vancouver Coastal Health around cultural competency, and I'm not going to go into any detail on these. And Scott, how's my time so far?
You're okay.
Okay.
A couple more minutes.
Okay. So big things are a training program on Indigenous cultural competency that's been developed by our Provincial Health Services Authority, really giving staff an understanding of the Aboriginal First Nations culture. We actually do on-site days with staff, with the First Nation, going out and seeing how they live and how they think about health and in some cases, their traditional practices. We've got some structural things that we do. So, for example, we have policies around tobacco, ceremonial tobacco use and smudging and those sorts of things. And we're trying to build a culturally competent environment by making sacred spaces available. And as well, we're trying to build some of the cultural safety aspects by working very closely with the First Nations Health Authority itself. Final thing I just want to highlight for you is our Aboriginal Navigator program, and I'll be quite quick with this. So this is a program, a very small program, where we have Aboriginal staff who are trained to help people navigate our system. So I've talked a lot about building the empowerment of the patient or client to be able to interact with us, but also we need to help them navigate the system. Navigation and navigators go back to the cancer side of things, where there's been some pretty good research about the benefits of navigators. A couple good examples up here are around survival rates and around being prepped for particular procedures. So we know that navigation is quite effective. We have developed this program a few years ago. These are the objectives for it. We have staff who will go into hospital or in the community. We can have a nursing unit phone them, or a family member can phone, or a patient can phone and say, I need some help navigating this system, or just I need some help, I don't understand what's going on. These are the type of things they do. They will work to help really navigate, as it says, through the system, often consulting with the healthcare team, trying to understand what it is the individual patient or client doesn't know, how to get them to know it better, and to get the system in place that will support that client through their journey. This is just another way of saying the same things. They have a brochure that talks to this from the perspective of the patient. There's a bit of a profile here of the clients they see. It's very varied. And again, I won't go into that because of time, but we have done an evaluation of it, and I just pulled out a few statements from the evaluation, which I think really highlight how navigation and navigators can support health literacy. This one here is from a navigator themselves, and they do talk about very clearly the work is helping get clarification of what the doctor is saying, and if they don't have that, to really find ways of getting the information for them, and then obviously building capacity. Here's a couple quick comments from patients themselves that we got through the evaluation. The one on the left here is, I didn't know where to go, hospital, leaving fishing, getting to welfare. So quite often it's helping the individual get what they need to be able to manage within the system that they're in. And on the right is an interesting one because it just shows, again, that without being able to navigate the system, many people give up and they just walk away from the health exchange that we want them to have. So there are some still challenges, and you're still holding 2 minutes, so I think it's gone, right? So exactly, it was still sitting there. So I'm not going to, there was a good evaluation done, but I'll just close by saying we did have an interesting workshop with traditional healers. The First Nations Health Authority sponsored that. And I don't have any sources for these two statements on the left, but there obviously is a huge amount of knowledge within the patient groups that we work with, and they are accessing other healthcare other than our more traditional Western healthcare systems. And so for health literacy, we do need to understand that, and we have to be culturally competent and work with them from where they're coming from. Thank you.